Welcome. My name is Dr. Susan Schultz, and I'm a geriatric psychiatrist at the University of Iowa Carver College of Medicine. In this part of the training program, we're going to talk about the important role of assessment in the decision-making process that directs effective and safe use of antipsychotic medications to treat dementia. We have developed the algorithm for treating behavioral and psychological symptoms of dementia to remind you of the key steps in this process before ever considering treatment with drugs. As the algorithm indicates, identifying, assessing, and treating factors that cause and contribute to problem behaviors is the critical first step. We'll refer back to this algorithm as we talk about assessment and non-drug interventions. Let's begin by thinking about Mrs. Annabelle Klein, the 71-year-old married female who was recently admitted to the memory care unit of the Pine River Nursing Facility. Key problems at the time of admission, including wandering and elopement attempts, distractibility at mealtimes, repetitive requests for her husband, intrusiveness, resistance to personal cares, and language deficits that interfered with communicating needs and wants. In the month since admission, Mrs. Klein's language skills have continued to decline, and her resistance to cares has increased. Staff recently observed additional changes in her behavior, which they have documented as including not recognizing her husband, who continues to visit daily, repetitive, suspicious statements about her husband's whereabouts, persistent nighttime wakefulness and restlessness, increased daytime restlessness, pacing, and exit-seeking alternating with napping, increased distractibility and refusal to sit and eat at mealtimes, and an 8-pound weight loss since admission. In Mrs. Klein's case, baseline problems related to taking other residents' belongings while wandering, resistance to personal cares, and difficulties communicating were addressed as part of the initial care plan. Although angry outbursts occurred, staff soon learned how to adapt their routines and approaches to accommodate her preferences and needs. Problems arose when a new group of behaviors emerged over a month-long period of time. Rather than settling into a routine on the unit, Mrs. Klein had a cluster of new problems that were different from those observed while living at home or early in her stay. Documenting the onset, type, frequency, and intensity of symptoms was undertaken to better understand the problems and possible causal and contributing factors. The Pocket Guide, Caring for People with Dementia and Challenging Behaviors, a step-by-step approach, will help remind you to document the behavior of concern and possible causes for the behavior. The decision-making related to medication use for behaviors in dementia is guided by the Need-Driven Dementia Compromised Behavior Model, or Need-Driven Model for short. The approach helps providers, including both primary care providers and staff caregivers, to think about how the person with dementia and the environment interact to cause behavioral and psychological symptoms. The model emphasizes that behaviors rarely come out of nowhere. Instead, they are a form of communication about unmet needs. Caregivers can learn to listen to the behavior, which means searching out what the problem behavior represents to the person with dementia, and then adjust the environment to help the person meet their needs and be comfortable. The Pocket Guide, Caring for People with Dementia and Challenging Behaviors, lists common challenging behaviors and reminds us of the physical, psychological, and other causes for these behaviors. As shown on the slide, the need-driven model has two main parts: background factors and proximal factors. Factors in each directly contribute to behavioral and psychological symptoms of dementia and interact with others to contribute to behaviors. Background factors include things that are unique to the individual with dementia. For Mrs. Klein, that includes being 71 years old, having moderately severe dementia, medical problems of constipation and urinary incontinence, and long-standing patterns of being a homemaker, dependency on her husband, and involvement with her 4 children into their adulthood. These factors operate in the background and are always present. Proximal or environmental factors include unmet physical and psychological needs and the influence of both the physical and social environment. Unlike background factors, proximal or environmental factors are constantly changing, which makes them a good target for both assessment and non-drug interventions. Proximal factors are often called triggers or antecedents to problem behaviors. Mrs. Klein's onset of new behaviors in the month since admission indicates the need for careful assessment to better understand causal and contributing factors to those behaviors. The first step is to document the frequency, intensity, and characteristics of each problem behavior. The next step is to identify, assess, and treat possible antecedents or triggers to those individual problems. For example, Mrs. Klein's nighttime wakefulness was examined to determine if environmental noise or light, time of retiring to sleep, daytime caffeine use, or waking to toilet may be part of the problem. The Pocket Guide, Caring for People with Dementia and Challenging Behaviors, suggests some potential triggers in each of the 4 domains, and the algorithm for treating behavioral symptoms provides a more thorough list of possible antecedents. Assessing physical needs and problems is an important starting point in the search for antecedents and triggers. Of note, Mrs. Klein's history was negative for coronary artery disease, degenerative arthritis, and other sources of chronic pain. She also had no history of diabetes mellitus or hypercholesterolemia. Medications included docusate sodium 100 milligrams twice daily for constipation, oxybutynin extended release 10 milligrams daily for incontinence, and a multivitamin. All medications were prescribed prior to her admission. However, additional history from her husband revealed 2 additional facts. First, oxybutynin had recently been increased from 5 milligrams to 10 milligrams on an outpatient basis prior to Mrs. Klein's arrival to the facility due to her persistent complaints of urinary symptoms. In addition, he noted his wife's lifelong resistance to taking any pills interfered with Mrs. Klein consistently taking her medications. Her husband did not think that she had been taking the medications regularly, if at all, and she refused to let him assist her by monitoring them. The primary care provider and care staff reviewed other possible contributing factors, but little changed in the areas of psychological or environmental causes. Since admission, Mrs. Klein had missed her husband and often wanted to go home. However, she enjoyed his daily visits and responded well to reassurance that he would visit again soon. Staff found ways to reassure, redirect, and engage her in enjoyable activities, and she initially seemed to be adapting to her new setting and routine. Her failure to recognize her husband during daily visits, combined with her increasing day-night confusion, restlessness, and inattention, all of which emerged in a reasonably short interval of time, raised questions about a possible new health problem that was causing delirium. As part of the health assessment, the Confusion Assessment Method, or CAM, was used to quantify symptoms of delirium. We've created a pocket guide to help you assess for delirium that includes the CAM. The CAM instructs the clinician to consider the diagnosis of delirium if the following 3 features are present. 1, acute onset and fluctuating course. That is there evidence of an acute change in mental status from the patient's baseline? And does the abnormal behavior fluctuate during the day? Secondly, inattention, including difficulty focusing attention and keeping track of what is being said. Either disorganized thinking, incoherent or illogical rambling speech, or an altered level of consciousness, then a delirium evaluation should be implemented. Mrs. Klein was positive for 1, an acute onset and fluctuation in course and behavior, and 2, difficulty in focusing attention. Physical assessment indicated that Mrs. Klein's vital signs were notable for orthostatic hypotension, such that lying down her blood pressure was 124/78 with a pulse of 82, and standing up her blood pressure was 102/70 with a pulse of 110. She was otherwise afebrile, and her physical exam was notable only for restlessness and poor attention. A laboratory evaluation included a complete blood count, or CBC, electrolytes, and urinalysis. The CBC was unremarkable, and the electrolytes demonstrated an elevated BUN of 32 relative to her creatinine of 1.1. Her urinalysis showed an elevated specific gravity of 1.08 with 3+ leukocyte esterase, 2+ protein, and 50+ white blood cells. Given the history and physical findings, the primary care provider determined that Mrs. Klein was experiencing, quote, compliance toxicity as a result of consistently taking oxybutynin 10 milligrams daily since she was admitted to the facility over a month ago. The anticholinergic properties of the medication caused delirium, which resulted in even worse oral intake than usual and dehydration. Oxybutynin toxicity also caused urinary retention and contributed to a new bladder infection. We've created a pocket card that lists some of the more problematic or common medications that may cause delirium or problem behaviors due to their side effects. This may be helpful when reviewing medications. The downward spiral of infection, dehydration, and escalating behavior problems were treated using a combination of medication and non-drug interventions. The primary focus was treating factors that contributed to delirium. The oxybutynin was discontinued. In its place, a behavioral urinary continence management program was instituted. Her urinary tract infection was cultured and ultimately treated with ciprofloxacin. An especially devised nutrition and fluids plan was instituted to improve her oral intake. Additional care measures were directed at reducing nighttime wakefulness and daytime napping, with an aim of restoring usually daily activities and routines. Target behaviors were monitored using checklists that were personalized to Mrs. Klein's problems. Over the course of the next month, Mrs. Klein's CAM score returned to 0. A repeat urinalysis showed no evidence of infection. The success of the food and fluids plan was supported by recording her daily intake, weekly weights, and absence of orthostatic hypotension. Daytime napping, exit seeking, restlessness, and nighttime awakenings returned to baseline levels. Mrs. Klein once again recognized her husband during his daily visits and enjoyed his company. However, repetitive statements about her husband's whereabouts persisted. Although her use of words was impaired, the gist of her worries had a jealous tone as she questioned who he was with and whether it was her again. Her intrusive and searching behaviors were now directed at finding her husband and that woman. Overall, her behavior and psychological problems were not a source of danger or intense distress to her or others around her. Medication decision-making relies on accurate assessment, documentation, and communication of facts, and monitoring outcomes so that care can be further adjusted if needed. In many cases, like Mrs. Klein's, antipsychotic medication use can be averted when there is clear communication about the behavior itself, frequency, intensity, duration, when, where, and with whom, and efforts to identify, assess, and treat antecedents and triggers to the behavior. Communication and collaboration among family and professional caregivers and health providers who prescribe medications is essential. By identifying and assessing Mrs. Klein's unmet needs, compliance toxicity resulting in delirium, use of antipsychotic medication was avoided. Of equal importance, documenting outcomes, whether using personalized behavior checklists, standardized behavioral rating scales, or physical health outcome measures, provides a basis for adapting care to best meet individualized needs. There are lots of choices for documenting behaviors. Some of the most widely used scales for behavioral symptoms in dementia include the Neuropsychiatric Inventory, or NPI, the Cohen-Mansfield Agitation Inventory, or CMAI, Behavioral Pathologic Rating Scale for Alzheimer's Disease, or BEHAVE-AD, and the Consortium to Establish a Registry in AD, or CIRAD. Delirium is often best assessed using the Confusion Assessment Method, or CAM, and depression can be assessed using either the Cornell Scale for Depression and Dementia, or CSDD, or Patient Health Questionnaire, or PHQ-9, that is part of the MDS 3.0. Patient-centered behavioral logs and checklists are also very important to tracking the targeted behavioral problem. Keeping close track of occurrence across shifts in long-term care settings often helps identify patterns related to triggers and antecedents. In summary, many of the behaviors that are labeled as being, quote, problems are the result of unmet physical, emotional, and social needs. Taking time to describe the behavior, consider it as communication, and then identify, assess, and treat antecedents and triggers is time well spent. So far, we have found physical causes for some of Mrs. Klein's behaviors, but we will soon learn that these do not explain all of her behaviors, particularly those due to dementia. In the next part of this training series, we will talk about non-drug interventions and how they were used in Mrs. Klein's case.